on, so we're going to make it happen. So, hi everyone, welcome to our panel discussion, All for One: Effective State Behavioral Health Crisis Administration. My name is Travis Atkinson. As I mentioned this morning, I'm the president of the Crisis Residential Association, and we've got a great panel here for you today. Before we get into that, I just want to make a couple quick announcements. We have our panel today right now, and then following that, we have a chat and chew where we're going to be breaking up into 5 or 6 groups just to talk about, to have a chance to connect and network with one another. I know it can be hard to see people that we know or that we want to know in the chat, and not be able to kind of do something closer to face. So that'll be happening after this session. And then also we will have breakout sessions following that, and then some TED Talks later this afternoon. So still got a lot of action-packed content and sessions that we're excited about. So I want to now introduce our panelists, which I'm just thrilled to have here. I can't tell you how excited I am to be hanging out with these folks and getting a chance to hear about the great work that they're doing in each of their states. So I'm going to start by doing some introductions of these friends and colleagues. So we have 4 panelists today. The first is Jennifer Armstrong. Jennifer joined the Tennessee Department of Mental Health and Substance Abuse Services in 2020 as Director of the Office of Crisis Services and Suicide Prevention. As a member of the Division of Mental Health Services leadership team, she provides vision, administration, and oversight of all DMHS crisis services and suicide prevention programs. Prior to her current role, Jennifer served as a Vice President of Customer Engagement Operations for Centerstone, providing oversight and leadership for customer engagement initiatives, including day-to-day management of a multi-state engagement operation for Centerstone, customer satisfaction, enhancing the customer experience, and improving the customer journey throughout the engagement process. Jennifer, welcome. My next introduction is Brad Munger. Brad has overseen service delivery networks in a variety of settings and from a variety of perspectives in the state of Wisconsin. As a licensed professional counselor, whoop whoop, he has worked in both private and public sectors for more than 30 years with a range of responsibilities from psychological evaluation to direct treatment and clinical and administrative supervision. He's currently a mental health planning and finance specialist in the Division of Mental Health and Substance Abuse Services within the Wisconsin Department of Health Services. And he's been a technical consultant and contract manager in several crisis areas. Brad, welcome to the panel. And then we have 2 panelists from the state of Texas. The first is Lucrece Pierre-Carr. She is the director of the Crisis Services Unit within the Behavioral Health Services section of HHSC, and she oversees the policy, program, implementation, and procurement activities of statewide behavioral health crisis, forensic, and jail diversion programs. Ms. Pierre-Carr has overseen the successful expansion and implementation of these programs across Texas over the years. And her colleague, Britney Rohsner, is also with us. Britney has worked for the Texas Health and Human Services Commission for over 4 years as a subject matter expert for multiple crisis programs, including crisis facilities, crisis hotlines, and mobile crisis outreach teams, and currently serves as the manager for crisis services. She has experience providing community services as a child and youth case manager and mobile crisis outreach team member. Fellow panelists, it is great to have you here, and I'm really excited to dive in. I want to make sure that we've got enough time to not just have a great conversation, but to also get some questions from the audience. So we're going to jump right into it. And so I have some of our information in this table here to give you some context for what these 3 states look like from a population perspective, from the number of counties. So for example, I don't know how many counties y'all's states have, but mine has about, I think it has 82. So as we look at a state like Texas, we have 254. Oh my goodness, that might be all the counties in the Midwest combined would make up, Texas. So it's going to give you some context. I've also got some population numbers up there, and we'll dive into these details a little bit further. But we're going to start with Jen Armstrong from Tennessee first, and we will go through each question with all of our panelists. Feel free to crosstalk, feel free to respond or ask questions of one another, and I'll try to field questions as well from the audience as we're talking. So the first question, Jen, is for you. Briefly describe the crisis services your state offers and how they are managed.
Yes, good afternoon, everybody. Thanks so much for having me, Travis. As Travis said, I have been in this current role for a whopping 6 months. And I'm very excited to be back in the crisis space. This is my passion. And I'm so honored to be able to serve in this capacity for Tennesseans. So I think this is our most recent infographic for fiscal year 20. It kind of outlines what services look like from the front door all the way through final disposition or connection to services in our community. We are blessed to have a full continuum of services across all 95 states through blended funding, through state dollars, and also our state Medicaid program, which we call TennCare. We have a statewide crisis line that we fund. And so based on where the person that's calling in crisis, what county they call from, it routes to the mobile crisis or crisis provider that covers that county in their catchment area. So anybody that calls should be met with a real effective triage. We're really working hard to standardize that experience across the board. So no matter who they get, it's the same experience. But effective triage, risk assessment, and really looking at what we can do to get that person connected to the right service at the right time. So that's not meant, people don't call that line just assuming that mobile crisis services are needed. It really is hopefully a good upstream diversionary resource. So we had over 124,000 calls last year, sorry. And again, that is a combination of two things. That's a combination of our statewide crisis line. Our crisis providers are also contracted to have a 24/7 local crisis line, and that preceded the statewide crisis line. We're working to figure out how we can maybe mesh the two. So that number reflects both, whether you call the local crisis team or you call the statewide crisis line. So as you can see from these stats, I'm so excited not only that that this many folks are able to access our services, but I think this infographic also speaks to the great diversionary resources we have within the state. So as you can see, last fiscal year, just from the telephonic triage and crisis work there, we were able to resolve 25% by phone. Of that total, 75 were referred to our mobile crisis teams. And so we have 13 state contracted crisis providers across the state. They're covering various numbers and areas within Tennessee. From there, we're blessed to have, as of 2008, we have crisis respite, we have crisis stabilizations units. We also have walk-in centers. So right now we have 6 providers across the state that are contracted to run 7 CSU and walk-in centers. And then 5 providers also offer crisis respite services. Through our mobile crisis efforts, we were able to divert 64% of those seen for face-to-face from a higher level of care, which is wonderful, through safe crisis management planning, quick connection to community resources, and only 36% were referred for inpatient. So to me, when you look at the people that are reaching out for help, we're looking at almost 75% of those we're able to divert from a higher level of care. So I'm so excited and excited to report that. We also have, in terms of higher level of care for uninsured, we have 4 state-funded regional mental health institutes, one in each kind of region of the state. We have one in West Tennessee out of Memphis. We have another one in Bolivar in West Tennessee. We have one in Middle in Nashville, and then we have one also in Chattanooga. Let's see. So yeah, in terms of a high-level overview, that's the continuum of crisis services in Tennessee.
And Jen, you've worked on both sides now as a provider and as on the administrative side. And my understanding is that Tennessee's been doing this for a long time.
Yes.
Some people could say that crisis as a service or an idea of a continuum is trending, so to speak, in the last 5 or 10 years. But it seems like you all have been making this a priority for decades now, of providing good care and having a good network adequacy so that people are receiving a consistent crisis benefit across the state.
Sure. We've had mobile crisis in place across the state for almost 20 years, and I believe we added Respite a year after that. So those two services have been available for almost 2 decades. And like I said earlier, the CSU and walk-in center followed almost 12 years ago. So yes, we've been blessed to have that infrastructure in place for quite a while.
Wonderful. Thank you so much for getting us started off.
Absolutely.
Lucrece and Britney, I want to turn the same question over to you now. And Lucrece, I'm sorry we didn't get to introduce our fifth panelist that showed up right behind your head there. But we'll get their name and their bio in a little bit. So Aaron, if you don't mind pulling up our Texas detail slide, and either one of you tell us a little bit about how crisis services work in your state.
So I'll take that one, Travis. Good morning or good afternoon, depending on where you are, everybody. As far as a description of the crisis services in Texas, so every county in Texas is served by a designated local mental health authority or a local behavioral health authority. The local authorities provide a wide array of services and supports, and also connect people with resources unique to their community. And so the various crisis services offered by the local authorities include prompt face-to-face crisis assessment, crisis intervention services, and crisis follow-up and relapse prevention services. The local authorities operate an array of crisis programs consisting of crisis hotlines, mobile crisis outreach teams, mental health deputies, various types of crisis facilities, and inpatient psychiatric beds. And so the crisis hotline is a 24/7 telephone service operated by trained crisis staff, providing crisis screening and assessment, crisis intervention services, and referrals. The mobile crisis outreach teams provide a combination of crisis services, including emergent care, which requires a 1-hour response time frame, urgent care requiring an 8-hour response time frame, crisis follow-up, and relapse prevention to people of all ages. The MCOTs respond to calls in the community and collaborate closely with community partners such as law enforcement and local emergency departments to ensure behavioral health care needs are appropriately addressed. And both the crisis hotline and MCOT services are available 24/7 and in all 254 of our counties in Texas. And so some local authorities also subcontract with local sheriff's departments to deploy a certified mental health deputy to address individuals in crisis. Mental health deputy is an officer specially trained in crisis intervention that works collaboratively with the community and the local authorities' crisis response teams. These deputies help to improve the crisis response system by diverting individuals in need of crisis services from hospitals and jails to community-based alternatives. Several of our local authorities operate crisis facilities. These crisis facilities may be staffed with mental health professionals, medical professionals, or others such as peer providers. And they offer assessment, support, and services to achieve psychiatric stabilization to individuals with behavioral health needs. The Texas Health and Human Services Commission funds different types of crisis facilities, ranging from the least restrictive to the most restrictive environment. And these facilities are crisis respite units, crisis residential units, extended observation units, and crisis stabilization units.
Now, can I ask you a question there, Britney, for a second?
Sure can.
You just reeled off 4 awesome crisis services that all have a residential component to it, if I understand that correctly. Like the EOUs, extended observation units, are up to 48 hours, and then you go all the way over to crisis stabilization, crisis residential, crisis respite. Most states have one of those things. Y'all have 4. Can you tell us a little bit more about, give us just the right amount of detail about how those work and why that's working for you as a state or as the LMHAs to have these different levels of crisis care that are all have a residential component to them?
Okay, you cut out a little bit, so I'll try to answer what I heard, and if I missed anything, you let me know.
Okay.
So starting at the least restrictive environment is our crisis respite facilities, and so these are for individuals with a low acuity level, and they offer short-term community-based crisis care. And like I said, the individuals served in the crisis respite unit pose a low risk of harm to themselves or others. And so from there, it kind of goes up with the risk of harm, if you will. And so the next kind of higher level of care is our crisis residential units. And so for a respite unit, the average stay is about 7 days. And for the residential unit, the max stay is about 14 days. And so with extended observation units, those provide emergency services for up to 48 hours for individuals in a psychiatric crisis. And these units are kind of the next level of care that can provide involuntary services for our individuals on an emergency detention. And so kind of when folks go to the EOU, they're kind of triaged to see, okay, does this individual need to step down to a lower level of care? Can they be stabilized if they step down, or do they actually need to go to a higher level of care? And then our highest will be our crisis stabilization unit. And these are actually the only licensed facilities that we have. And so those are regulated by our regulatory division within HHSC. And so those have a list of licensing standards that they do have to abide by. And the CSUs can serve individuals on emergency detentions or individuals on an order of protective custody. So that's kind of a high-level overview of the various facilities. Now, not every single one of our local authorities has each option of crisis facilities. They may have a respite and an EOU, or they may just have a CSU, a crisis stabilization unit. And so it kind of varies across the state.
Got it. Thank you.
Sure. And then our last crisis service that we provide funding for is for local authorities to provide inpatient psychiatric services in licensed psychiatric hospitals to individuals to relieve acute symptoms and restore their ability to function in a less restrictive setting.
Great. And then Lucrece, do you have anything that you'd like to add?
Sure. I'll just put a plug out to our legislature. You were asking about, these different programs and our ability to operationalize and fund them. And so our Texas legislature put a lot of investment in these, in our just kind of our crisis array back starting in around 2008 or so. And so that really kind of helped start like our statewide crisis services. So it was a huge influx of funding just for crisis. And so that allowed us to be able to fund, the hotlines and the mobile crisis outreach teams through all 254 counties. And then as Britney noted, the other facility type crisis services, they were on a competitive basis. And so, and then they were based on needs. So they're not available at this time everywhere. And some of the local authorities, they have several. And so they use that as a step down option. And so they're able to help transition people to where they need to go. So we're very, proud of the services that we have. We've been able, again, since I've been with the state, I've seen these services expand, and there's still more need for them. And so we're just glad that we are able to offer them. But if I had my way, every area in Texas would have a variety of different options. Okay.
Thank you, Lucrece and Britney. So I'm hearing a little bit of a trend here now with Jen and then both of you that first of all, crisis services are a statewide priority, and second of all, that this isn't trendy. This isn't like you're trying to jump on the bandwagon, but that this has been an intentional process that's been going on for quite a while. So now I want to head over to Brad. Brad Munger, so glad to have you here with us. I've just so much enjoyed learning about Wisconsin's crisis system in the last few years, and what a great thing you've got going. But I'm not going to speak for you. Tell us about crisis services in the state of Wisconsin, and I'll ask Aaron to switch over the slides back to the other deck.
Yeah, thanks, Travis. I just want to make sure people can hear me.
Yes.
Can you give me a nod if you hear me all right? Okay. Wisconsin is I don't know how many Wisconsins will fit inside of Texas, but we're a much smaller state. We have 72 counties in Wisconsin, and we're a home-based rural state. So each county has their own particular way of doing things. Under our state statute, which oversees the mental health system, and then we have an administrative rule promulgated by the Department of Health Services, which then counties, if they meet certain standards within the rule, then they're eligible to collect Medicaid reimbursement for their crisis services. So most of the counties in the Wisconsin are providing services that are Medicaid reimbursable. There are a few that don't have crisis services that are Medicaid reimbursable. And then we also have counties that collaborate and work together where a single crisis program will serve more than one county. We have the same civil detention standards as most places, with dangerousness being the requirement, dangerousness due to mental illness, and we're duty bound to treat in the least restrictive environment. If counties are needing to detain someone, however, under a civil detention, law enforcement is charged with the responsibility for initiating that emergency detention. There are a couple of other ways to initiate the emergency detention, but typically it requires law enforcement. So that de facto involves law enforcement in almost all of our emergency detention situations. Our crisis programs then partner with law enforcement to do an assessment of the individual and arrange a disposition plan. All of our crisis programs that are certified and receiving Medicaid are required to provide 24/7 phone service, a crisis line, and they're required also to provide 8-hour a day, 5-day a week walk-in service, and then 8-hour a day, 7-day a week mobile service. And typically mobility is to certain locations, it's not to every location, but they'll usually end up meeting with law enforcement in the emergency department where someone has been taken by law enforcement. So they'll conduct a crisis assessment and then make a decision with the consumer as to what the best plan is, diverting as much as possible. So those diversions can range from developing a safety plan with the consumer and his or her family or natural supports, or it might be a diversion to a residential stabilization facility. Optional residential stabilization is another component to our crisis rule. So counties, if they have the resources, will set up residential stabilization facilities. They can also do a 23-hour living room model, but we don't have a lot of counties that are currently providing that.
Brad, you got some pure respite facilities in your state, is that correct?
That's a good point, Travis. We have those. They run sort of parallel to the crisis system. We have 4 peer-run respite facilities in Wisconsin. They don't take referrals from the professional agencies like crisis, but a consumer can self-refer. So if a person got in touch with crisis, the crisis program, depending on the individual's needs, may recommend that they contact one of the peer-run respite facilities. And those 4 facilities serve individuals from all around the state. Obviously, it's not geographically convenient for everyone, but they are open to anyone from around the state.
Okay.
And the crisis residential stabilization facilities are an arm of the crisis program, and they are also reimbursable through the Wisconsin Medicaid program. Our reimbursement rate is rather limited, so that constrains the amount of service that our crisis programs are allowed to provide. Another challenge for us in Wisconsin is that our rule is written as such that we have to only serve the consumer with one crisis staffer unless there's evidence that the situation would be otherwise dangerous. So that precludes having two staff respond to the same situation, which would, if that were available to us, we would be able to then not utilize law enforcement as much. But law enforcement is typically called upon for crisis situations just to secure the scene. Another, go ahead, Travis.
I was going to say that I think that's a challenge that creates a disincentive in other states too. When two people can't bill for the same service, or for a service, either at the same time or in the same day, sometimes that can disincentivize case managers or clinicians from visiting a crisis residential or visiting a psychiatric hospital because service is already getting billed. So I imagine some of our audience can relate to that challenge.
Yeah, absolutely. The other thing I was going to mention is that although we have stabilization facilities around the state, there aren't a great number of them. And we also don't have a great number of psychiatric hospitals. We have 2 public psychiatric hospitals operated by the state. So they're geographically inconvenient for many of the counties across the state. So there is a real incentive for counties to be able to provide that residential stabilization when possible and divert from hospitalization.
Okay. Thank you, Brad. We're going to move on to a couple other questions to make sure that we've got time, and we've got great questions coming in the Q&A. So thank you. Also wanted to say Texas is representing heavy in this session. Some of Britney and Lucrece's colleagues, as well as people from Integral Care and Wood Group and Denton MHMR. So very cool. Jen, I want to come back to you for our second question, and that is what benefits are crisis providers afforded in your state that help them to offer high quality crisis services? These might be things like technical assistance, a conference, a regular call, site visits. How is your department helping to support and promote the success of your crisis network?
Sure. Well, I will say my onboarding into this role has been quite an anomaly during COVID. So I think you and I have talked before, Travis, that is, it's hard enough to really want to get in there and get your claws into how we can best support our crisis providers during normal times, right? And then add COVID on top of that, It just kind of amps it up. So for us, I think historically, from the provider side, I will say I've always felt so supported by the Department of Mental Health and Substance Abuse Services. It's more of a collaborative relationship. And I hope that our providers can continue to say that now that I'm in this role. But I will say prior to COVID, we did have things like quarterly partner provider meetings where we would pull in all of our law enforcement, all of our hospital partners, our crisis providers in a certain region, and really troubleshoot around what are the barriers to accessing services, what are the barriers for law enforcement in terms of their capacities, things like that. So that's historically existed. And there's always been an annual conference. I will say post-COVID, what I know now, I know truly my role is to help them be successful in providing excellent crisis services. And so I'm available. I can tell you there's probably 3 times a day I'll get a call from a crisis director troubleshooting a problem case where we may have to pull in one of our MCOs to help identify resources. So there's a very close relationship around ongoing consultation and support and technical assistance to our statewide providers. Outside of the ongoing, like I said, when COVID hit, I slid on into this role. I think the week that everything shut down in Tennessee, and so we began having weekly. First, it was daily calls with all of our providers to go, what is going on? How do we continue to provide services in a way that's seamless, but also effective, efficient and effective, I would say. And then More recently, we've gone to biweekly, plan to go monthly, but really looked at how do we implement things. And I'm sorry, I may mesh two questions together, Travis, if that's okay. I think you can't talk about one.
Yeah, go ahead.
You know me.
I'm just here to facilitate. I can't contain you, Jen.
Okay. How in the heck do we get telehealth out there? Historically, we have had struggles implementing telehealth in all of our ERs or in the majority of our jails. I think what COVID has done, if there's anything good, I hate to even say that out loud, but it has really forced us to catapult in that direction because there's out of necessity. So with that, we have ongoing conversations. We have weekly calls with law enforcement partners, things like that. So ongoing communication. I know that you recently joined, Travis, our annual conference, and it was virtual. It was the first that we've done virtual. And historically, we've always done an outstanding crisis worker award where everybody nominates somebody and it's that time of celebration for that worker. Well, this year it just didn't feel right. And it was more of how do we really just take a breath and celebrate the work that you guys are doing out there in the field every single day. And so we turned our conference into a celebration of what we called the heroes of today, because they really are. So really more than anything, we try to give them as much consultation ongoing as possible. We have scheduled calls. We have annual events with them. But more than anything, I think that, in my past provider work and now in this role, I think more than anything, it is truly felt to be a team effort where we're all going to figure this out together. If there's someone we can't figure out where to place them, and we will all jump on a call that day, troubleshoot, pull in a pair, pull in whomever we need to get the work done. So again, I think I keep using the word blessed, but I really do feel that way. I think that we're blessed to have such a collaborative relationship across the state, whether it be provider, whether it be community partners, whether it be, at the state level. And I could go on and on, but I'll let the others speak. But again, no. I think that it just is a matter of, of how you view your role to be as a state and how we oversee these programs. But for us, it's definitely a collaborative effort.
Thank you, Jen. That is very helpful. And I just want to mention, I did get a chance to sit in on the Tennessee conference, and what an honor it was to your crisis employees to be celebrated like that and to be acknowledged. I don't think we do enough of that. And so for the state to take that stance and to say, we see you, we value you, I think that is huge, and hopefully put some more gas in the tank for your workers who have just been, I imagine, tirelessly pushing ahead and adapting always, but especially in these last 6 months. So sure. Same question over to Lucrece and Britney. Tell us about, what does Texas HHSC offer as far as benefits or support to your crisis providers that encourage them to deliver high quality services?
Hi, Travis. Can you hear me?
Yes.
Okay, great. I had some connect. It was going in and out there, but great. Okay. So HHSC offers various types of technical assistance to our providers. The first is that we facilitate routine technical assistance calls. These routine calls occur monthly statewide, and they're offered according to the subject matter, such as crisis facilities has their own call, MCOT, mental health deputies, and they occur via teleconference. Some of the topics that we discuss on the technical assistance calls is we review various training opportunities available. We provide agency updates and discuss crisis-related data and measures. We will also discuss program standards, revisions, if we're going through them, and solicit any feedback on the proposed divisions from those on the call. And then we'll also have guest speakers, and these may be internal to HHSC, or we occasionally have an external guest speaker as well. And then the other type of technical assistance calls that we offer to our providers is provided if requested or needed to clarify the program requirements and standards. So these calls are targeted towards an individual contractor's needs or local authority's needs and documented in a form for tracking across the various programs. Additionally, we will receive internal requests for technical assistance from our quality management team if after they conduct a quality management review and discover that some technical assistance may be needed for the program. And we also receive technical assistance requests from our Office of the Ombudsman if there are any rights concerns discovered.
Awesome. Thank you, Brittany. I want to turn the same question over to Brad now. And I'll preface this by saying, I think it was last year I got a chance to attend my first crisis intervention conference with the state of Wisconsin. And holy cow, y'all, it was at the Kalahari Resort. I think there's hundreds of people at this thing, right, Brad? 600, 700 people that all work in crisis, just like such a saturated group that gets to talk crisis for 2 days. I see that as a benefit, but tell us a little more about that conference, and then what other support your state provides to make sure these crisis providers can do the work they want to do.
Well, it's been great having you at the crisis conference the last 2 years now, and that crisis conference is the outgrowth of what we call the Crisis Network, which came into existence 24 years ago as the rule for the administrative rule was being developed for crisis intervention within Wisconsin. So that crisis conference draws anywhere from 400 to 700 people annually from all different parts of the behavioral health system. The Crisis Network itself is a group that typically was meeting quarterly prior to COVID. Once COVID came in, we amped up the meeting frequency, and now we're meeting twice a month via Zoom. And it's an opportunity for crisis programs from all these different counties programs to share information and get updates. We also have opportunity to convene our crisis partners from around the state in other ways too. We currently have a work group going on looking at expanding and improving crisis services around the state, and looking at specific initiatives which would be helpful to the state overall. Such things as reducing the duration of time it takes to do medical clearance prior to hospitalization, working out protocols for that, as well as a number of other initiatives that would benefit the programs. This is built on kind of a prior history where we've engaged the county programs, the county crisis programs in a learning collaborative model. There's and in 2017, 2018 of that, which is referenced on the handout, of things that could be done in a rapid cycle quality improvement process that counties could implement pretty easily within their systems and adapt, adopt, or abandon a change that they make to their system. So I'd encourage people to take a look at that. We also have a listserv through a subscription service at GovDelivery, so we get announcements out to our crisis programs so that they all stay informed of developments. We also sponsor grants to improve our systems. We've provided grants over the years to improve crisis response to people who are living with dementia, to people who are, to programs that are serving rural areas, as well as we also have some grant funding from the state to help support crisis intervention team training. And so we do quite a bit of that, and we collaborate, as I said before, quite a bit with law enforcement. And additionally, we have the effort of collaborating across county lines. So one grant-funded initiative involved setting up walk-in crisis services at a number of emergency departments and then linking them all together with a telehealth model, so that one crisis professional in one emergency department would be able to link to these other 7 emergency departments and be able to provide crisis services to a larger rural geographic area. We also partner with some of our universities to do a lot of training. We have a core training that's put together by the University of Wisconsin Green Bay Behavioral Health Training Partnership. And that saves on training costs for our crisis programs because it's already been developed and available. Among other things that I can go into as you may have questions.
Awesome. Thank you, Brad. In the most professional way, it sounds like each of y'all as state behavioral health entities are kind of putting a snuggie around your crisis providers, and just try it, and maybe they wouldn't say that, but I look at, I get it. I'm fortunate to see what states are doing across the country. I know a lot of them don't even know what services they offer and how many of them there are or where they are. I think that's an area of improvement for a lot of states, that they should have somebody in their office or their department that is an expert in their crisis services. So I'm really encouraged to hear all of these ways that you're trying, I feel like, to ask the question, how can I be the most helpful as it pertains to my role in the oversight of this network? I am going to pivot and actually go to the Q&A here, because we've got 1 or 2 more questions, but I think they're going to be answered in our discussion here. And I trust our participants and our attendees to come up with better questions than I can. So a lot of people have been asking about crisis respite. And so Lucrece or Britney, I'd like to start with you in this space. Can you help us to understand more about the crisis respite model? We have members and we represent members who operate peer respite facilities, which are entirely peer operated respite homes. Usually they might be, let's say, like about 4 beds. There's less than 100 of these across the country. When you say crisis respite, can you help us understand what that means and how we might be able to compare it to other services in different parts of the country?
Sure, I can go ahead and jump in for that. So the crisis respites, like I mentioned, they provide short-term community-based crisis care for individuals.
Well, looks like we had Britney freeze up here a little bit. Lucrece, do you want to?
Functional impairment that.
Sorry, Britney, go ahead. Keep going. You just froze up for a second.
Okay, sorry. I'm sure it was a great picture when it froze too. All right, so I was reviewing that, individuals in a crisis respite pose a low risk of harm to self or others, but they may have some functional impairment that necessitates direct supervision and care, but they do not require hospitalization. This is the least intensive facility-based crisis option, and these services may be provided for a few hours or a few days. And so many people in these programs have experienced an event causing significant distress, or having housing challenges, or they have loved ones or caretakers who are seeking temporary support or supervision for the individual that's receiving the services.
Okay.
And so, was that good?
I was going to.
Oh, we do have, we do. So we are kind of working up on one last plug. We're working on beefing up our standards, or our developing standards really, for peer run respites. Right now we have 1 facility that's peer run. So we are kind of working to beef up those standards so that we can have more and be able to provide some guidance on those.
And I'll piggyback off of
that was all.
Britney. Can you all hear me?
Yes.
Okay, great. I don't think Britney can hear me, but I'm going to piggyback off Britney and just say, and the settings they vary. And so some of the local authorities, so again, the local authorities operationalize these programs for the state. Some are in, a home. Some are just standalone facilities. Some are even in hospitals, kind of rent, the local authority is working with their partners to operationalize these. And so Britney is correct. There are more peer type facilities coming up. And so we're working on our standards, our crisis standards, to make sure that we're in line with best practices as it pertains to those different type of respite programs.
Great. Thank you. I want to turn the next question over to Jen. Jen, this comes from Christina Rossi in California. She says, I'm curious if there are any issues with persons served crossing county lines to access services that might not be available in their own county.
Not really, because like I said earlier, there are limited number, unfortunately. Well, let me back up. Mobile crisis is available in all counties, but as outlined earlier, there are much fewer CSU, walk-in centers, respite, diversionary options, and they're very limited. And so what our crisis providers work very hard to do is to collaborate in situations like that. For those funded for CSU and walk-ins or respite services, there is transportation provided, to make sure that that's not a barrier with us being having such a huge rural presence. But not really. I think more than anything, it's not access to, it's more how to get them there than anything. And we try to work that out amongst one another. We pull in law enforcement when we can, but not really.
Great. Same question to Brad. Brad, is it okay for people to go to a different county to access a crisis service that might not be available in their own county?
Good question. That does happen quite often in Wisconsin. We don't have a statewide crisis number, not a singular number. The counties all have their own numbers. Some counties partner with a phone service where they will share a number, but many times those contract agencies which operate phones will also assist somebody in getting to a residential stabilization setting in another county. We also have developed a new rule for youth crisis stabilization. We've had a lot of problems with youth going to the hospital and needed to beef up our youth crisis services. So a new rule was promulgated and some money was attached to seed the development of 3 youth crisis stabilization facilities. And those are scattered over those locations in the state. And presumably those will, once up and running, will start accepting people from neighboring counties. We also had only 4 National Suicide Lifeline provider programs within Wisconsin, only had 4 members. So the state recently paid for the development of a statewide NSPL Lifeline backup center to take calls from the balance of the state and then carry the overload of the existing Lifeline providers. So that helped us increase our capacity here too, and represents a sharing of resources around the state.
Okay. I'm going to open up this next question to anyone. Do you have peer supports answering crisis calls or working on mobile crisis teams in your state?
I'll be glad to take a stab at that.
Great.
Yeah, so as part of the expectation, as part of the contract with each of our providers, there is an expectation that they utilize peers in some way, whether it be on the crisis line, on a mobile crisis team. I know that in Tennessee, the majority of the providers do have at least one peer support presence on their front door in terms of the line. And then I think the majority have at least have one on their mobile team as well. But the expectation is that they're used in some way. I think that we continue to talk about how to make that not so vague, in terms of how they're best utilized, because they are so very valuable with it, in terms of engaging those reaching out for help.
Okay, great. Anyone else?
We promote it, and I'm envious of Jennifer's ability to have them on the teams. We don't have certified peer support specialists on our crisis rule at this point, but in a revision of the rule, it would be nice to have that so we could start seeing more peer specialists on our crisis teams. We only have a handful of crisis teams that utilize peer support specialists.
Okay. I want to try to get to as many questions as possible. We got just a little under 10 minutes left. This one comes from Remy Romanowski Pfeiffer in Michigan. She says, as a state administrator, how do you personally stay connected and grounded to the needs and desires of those being served in the crisis system?
I think for me, it's pretty easy because I came from the provider side. So I was boots on the ground. I was doing the assessments or overseeing those programs. I think now that I'm in this role, I'm not very far removed from that. So I'm going to use the word blessed again in that way. But I think more than anything, staying connected, having an open door or open phone at these days or open Zoom policy, so that that the crisis providers really do know that they can always reach out for consultation and support.
And I'll also answer that. And so for Texas, I think, because the local authorities provide the crisis services for us, that does put us a little further away from what's happening. But I think the collaborations that we have with them, it really keeps us in the weeds of what's happening. So we have a lot of opportunities for collaboration. When we're revising our standards, we include those staff from the agencies. Also, as an agency, HHSC, there are different advisory groups that include different stakeholders. Some are consumers, parents. And so, when we get into those meetings, it really does, remind us of what we're doing and why we're doing it. And so just having that constant communication and collaboration, making sure that we are understanding what the issues are, because Texas is so huge. And I know we didn't get to that question. There was a question about challenges. And for our state, the challenges, differences in service delivery for our rural and urban areas. And so, I come from a large city. I'm from Chicago, Illinois. And so moving to Texas and, there's rural in Illinois, but there is rural in Texas. OK, everything is bigger in Texas. And so of the 254 counties, 233 of them are considered rural. Wow. And so, so the population is concentrated mostly in the metropolitan areas, the areas that you hear about, nationally, Houston, Dallas, Austin, where our offices are in Austin, Texas, San Antonio. And so so I've appreciated just learning, really what their challenges are. And there are real challenges in the rural areas as opposed to urban. And so we take all of that in consideration as we're writing policy and developing our contract standards.
Great. Last question or two here. If obviously the majority of our attendees are crisis service providers. So if you had any advice on how they could initiate these conversations in their own state to work towards the provider network support that y'all have built and that you maintain now, what would it be? What would be your advice to get providers and administrators on the same page, valuing crisis services?
I think mainly reaching out to your state authorities and asking for that networking opportunity. Ask them to help facilitate a crisis network so that the various providers can get together and share information. And out of that, you can develop learning collaboratives and crisis work groups in the development of policy or new initiatives.
The last question I want to ask y'all is, COVID is having a huge impact on state budgets, Medicaid budgets, things like that. We also know that crisis services save money. So how are you balancing that tension in your state? I know that some of you don't necessarily make decisions over the dollars, but how are you balancing that tension in your state when people might be looking at, say, a mobile crisis budget or a crisis call center budget as being on the table of being severely reduced or cut, when in fact you're going to see your inpatient and your ER costs go up if you do that? How are you handling that tension as a department and trying to make the best decisions overall for the people in your state?
I would say, luckily in Tennessee, we have not had to experience any cut to programming, so that's been huge. I think beyond that, it is really just about being very transparent with our providers, so that they're not worried, at least keeping them informed of what we know. Because as you said, Travis, we're not, that's above my pay grade in terms of that. But I would say, luckily we have not had to experience that. I think more than anything, that's a question that's been asked on every provider call. It's just being very transparent about what we know, what our plans are to continue to provide efficient services amidst the pandemic.
Great. Any others?
Well, in Wisconsin, Medicaid is in our same department, the Department of Health Services, and I know Medicaid, and the people in the Division of Medicaid Services are really interested in conserving costs overall. And, to the extent that if you provide good crisis services, you limit emergency as well as inpatient hospitalization costs. But you have to keep a mind's eye to, how costs shift, from law enforcement to county human services to Medicaid and so forth, and working together to minimize the impact on all those systems from a cost perspective.
We could talk for a long time. I could talk for a long time. Y'all are amazing. Jen, Lucrece, Brad, Brittany, thank you for being on this panel today. This is seminal. This is really important to be having these conversations and show this other states, other providers, the whole country, what good crisis service support looks like. So thank you for all the work that you're doing, and thank you for joining us on this panel today. So attendees, if you've been looking at the chat,